further ado, it is my pleasure to introduce Dr. Rebecca Karp Leaf. Dr. Rebecca Karp Leaf is an assistant professor of medicine at Harvard Medical School in the Division of Hematology at Massachusetts General Hospital. Dr. Karp's clinical expertise is in classical hematology, including hematologic complications of pregnancy and the porphyrias. She is co-director of the Massachusetts General Hospital Porphyria Center, which, by the way, happens to be the largest porphyria clinic in the New England area. She is actively involved in clinical research, including studies on the intersection of reproduction, health, and porphyria. Originally, she is from New Jersey, but now she calls Boston home. She enjoys spending time with her family, running, taking care of her mischievous cat, Siberian cat, Winston. We are very lucky to have Dr. Karp Leaf as not just here with us today, but also as a porphyria specialist and member of the UPA's Scientific Advisory Board. Dr. Karp, thank you for being here with us today, for imparting your knowledge with us, and for allowing us to really pick your brain as we hear your presentation and dig into your brain afterwards with some of these questions. So with that, I will give you the mic and we will get to the questions after the presentation. So please take it away, Dr. Rebecca Karp Leaf.
Thank you so much, Myra. Hi, everybody. It's so nice to be here, to see some very familiar and friendly faces. And as Myra said, I'm a porphyria specialist at MGH in Boston, and hopefully we'll learn a bit together. But I think the bottom line of a lot of this is we just need more information, more data, more research, and moving forward with that together with your questions and stuff like that. So I'm not a reproductive endocrinologist. I know some of the questions we received previously were specific to IVF. I can try to answer those as best as I can, but I'd actually like to do another session at some other point with a colleague of mine who is a reproductive endocrinologist, and we could sort of go through those technicalities. But I'll try to do my best, and I can also get back to you over email. But so can you guys can see my screen? Yes. Okay. Thank you, Meg. Let us begin. So again, I'm just going to talk for a little bit, and then we'll go on to the question and answers. So just some background. So what is porphyria? We always talk about porphyria, but how do I really conceptualize it? How do I explain it to patients in clinic? How do I explain it to my family members who ask me, sort of what I do? So I talk about, the importance of heme. So heme is a molecule that's present in almost all the cells of our body. And it's the main component of, let's say, hemoglobin, which is, in the red blood cells that carries oxygen. It's also important for drug metabolism. And there are 8 steps to make heme. And porphyria is when there is a disorder or a defect in one of those steps, and that leads to a certain type of porphyria. So I kind of think about it like 2 ways. Like you can think about it as a river. So you have like sort of where the river is starting, the precursors to making heme, so succinyl-CoA and glycine. And then at the end of the river, you have your heme. And porphyria is when you sort of have an obstruction in that process, or like a dam that goes up, in the river. And it's really when you turn on the faucet. Let's say that there's like a big flood and there's a lot of water sort of coming down that stream trying to make heme. But if you have an obstruction, if you have a dam there, you have a buildup of all of those, all of that water that sort of spills over and causes damage from that spillover. Or some people explain it, like an assembly line. Let's say, I don't know, you have an assembly line with eight steps to make a car at the ends. The car is heme. And let's say, step number 3, that particular worker isn't really doing his job correctly. And he's only like, putting the wheels on half the time. So when that happens, and let's say the demand for making cars goes up and the assembly line is trying to work, you have this stop at step number 3. You have all of these wheels that build up and all of these like half-formed cars that build up. And then that's those, preformed cars or those wheels, those are the toxic substances that build up in porphyria and cause the symptoms. So anyway, that's how personally, that's how I sort of, conceptualize what we're talking about. So I know, most of you are very familiar with this, but there are multiple types of porphyria. Today, we are talking about the acute hepatic porphyrias, and that's when you have buildup of those porphyrins and porphyrin precursors in the liver. And those include acute intermittent porphyria, which is the most common, hereditary coproporphyria, variegate porphyria, and the very rare ALAD porphyria. And this is, it's a busy slide, but it's just sort of showing where heme is made, where you're getting these sort of buildup of these precursors. So again, it's this 8-step process. About half of it takes place in part of the cell called the mitochondria, the other part in sort of the cytoplasm, the sort of jelly part of the cell. And again, where that, obstruction is what type of porphyria that we think about and the symptoms that we see with that particular type. So, and 80% of heme is made in the bone marrow, but 20% is in the liver. And again, it's that liver heme and that liver production of heme that causes the acute hepatic porphyrias. And triggers, I know, everyone is aware, but includes certain medications. So sort of the quintessential one used to be barbiturates. We don't really use barbiturates that much anymore, but, when those drugs were really more commonly used, they were, very well-known triggers. The luteal phase of the menstrual cycle, which is really progesterone, and we'll talk about that, fasting, stress, and myriad other things. And sometimes it's even hard to just identify that trigger. So these are the current therapies for acute hepatic porphyria in general. So acute treatment, that's, when somebody comes in having an acute attack, abdominal pain, numbness and tingling in the legs and the arms. As you know, it can lead to seizures, respiratory issues because of the nervous system involved in the respiratory system. So our first go-to treatment is Heman. And Heman is actually, it was first discovered in the 1970s, and it's a human blood derivative, and it's basically giving back that heme. So you tell the body, okay, you don't need to make more cars. You don't need to turn on the faucet. Like, we can cool down this process. Plus it's giving back the liver that heme that it needs. It usually takes a couple of days to work, and we try to give it in our outpatient infusion center if possible. Pain medications, of course, glucose, intravenous fluids, and we always want to make sure that, we pay close attention to people's electrolytes. People can be, nauseated, vomiting, not taking in, enough food and water. And then preventative strategies. So how do we prevent these attacks from happening? So gavocerin, I'm not going to spend too much on gavocerin today, but it's a targeted medication that was approved in 2019 that really, again, what it does is it targets the first step in that heme making process, and tells it to, again, to stop a bit, to cool down a bit. So you're not sort of revving up that assembly line. That's really what gavocerin does. It's a monthly injection. Sometimes we use Heman to help prevent attacks as well. A GnRH analog like Lupron, we'll talk about that in a bit, but that's, specifically for people who have menstrual cycle related attacks. Of course, we want to always modify environmental triggers and stop any medications that may be culprits, and a liver transplant is curative because, again, it's the liver where you don't have enough of a particular enzyme, and a liver transplant gives back that enzyme. So let's talk about a case. 38-year-old woman presented with 2 weeks of blisters over her face, face and hands. She also reported dark urine, sort of like this cider-colored urine. She had had a Skyla IUD, which was, progesterone-only IUD that was put in 2 months before she initially came to our clinic. Periodic abdominal pain, and her lab showed that she had a high urine PBG and a high urine ALA. And we did genetic studies, and she was found to have a PPOX variants, which is consistent with variegate porphyria. And variegate porphyria is one of the acute hepatic porphyrias in which you can see not only what we call neurovisceral symptoms, so the abdominal pain, neuropathy, that numbness and tingling, seizures, but you can also get blisters on sun-exposed areas. So we're here today to talk about women's health and acute hepatic porphyria. Again, I'm very passionate about women's health. So even before I started doing porphyria work about 5 or 6 years ago, I'm trained as a hematologist, and one of my main focuses has always been women's health and hematology and pregnancy and hematology. And one of the big things that hematologists are called upon to do in pregnancy is help if people have blood clots, or if they have blood clots while on birth control. Some birth controls can increase your risk of blood clots. So I've always sort of been interested in contraception and how it relates to hematology. So now being involved in porphyria, I think that this is really an area that desperately needs more study. So that's anyway how I got into it. So let's talk about sex hormones and acute hepatic porphyria attacks. So acute attacks and just symptomatic porphyria in general really affects women of reproductive age. So 80 to 90% of all cases of either acute attacks or symptomatic people with AHP are women. And so it's like, it's maddening that we don't have any more data here. Like acute intermittent porphyria is inherited 50-50. So, 50%, you have a 50% chance of getting the gene if you're a man or a woman, but it's really the women who are affected. 10 to 40% of women have attacks during the luteal phase. Again, so this is the luteal phase. So, this is sort of your period, right? And, day 0 or day 1 is when you start bleeding. And then you go, day 14, and these are all the sort of hormone levels. Day 14 is when you ovulate, and when you get that, that egg that goes out of the ovary. And that is really, that happens sort of at the when you have this LH surge that sort of gets that egg out. And then you can see toward the end, you have this progesterone surge, which is in case you do get pregnant, you need sort of higher progesterone levels in order to sustain the pregnancy. So that's Mother's Nature's, way of saying, well, if your egg is fertilized over here, you need the progesterone to sustain the pregnancy. But again, it's the progesterone surge that we know, the progesterone, that really what progesterone does, it's like when you turn on the faucet for that river, or when, the foreman of the factory is saying, all right, triple your car making, assembly line, whatever it is, that the progesterone sort of does the same thing to your heme drive. It says, rev it up. And then if you have a blockage somewhere, then you have the spillover. And by the way, if anyone has like questions during this, like totally feel free to raise your hand. If I don't see it, Meyer, just let me know. And because I want this to be like interactive. So as I said, because you may I don't know if it's like, a burning question, you don't have to wait till the end. So progesterone is as I said, a potent inducer of ALAS1. That's the first step in heme production. Again, turns on the assembly line, turns on the faucet. And again, we know that sex hormones are important because in most women, symptoms begin at puberty, or, but they don't start before puberty. And in some women, they can get better with menopause, for sure, not every woman, but there is, a relationship in about 50% of patients. So this was sort of one of the first, outside of Heman, which again sort of shuts down the whole process. Researchers thought, how can we sort of reduce these levels of sex hormones, hoping to prevent acute attacks? If we can get those progesterone levels down, maybe we can again cool things off from a different angle. So they started looking into GnRH analogs. So this is something called Lupron. Lupron is used for a lot of things in medicine. Actually, probably the most common use for Lupron is men with prostate cancer. So it really just shuts off hormone production in the pituitary. It shuts off testosterone, but it can also, also shuts off estrogen and progesterone. And basically your pituitary is a gland that tells, in women, your ovaries to produce certain sex hormones. And Lupron sort of, from above, shuts everything down, sort of cools everything off. And in 1984, there was the first case report of this medicine, a GnRH analog to treat acute hepatic porphyria symptoms. And this is just sort of one patient, and it sort of shows the progesterone levels. So this is the Lupron-like drug. Progesterone started, and then it, went way down. So, and this patient had improvement in her symptoms. So again, it's helpful in about 50% of patients who have menstrual-related attacks. Lots of questions about Lupron. How long do you keep it on? Some people will say, just for a couple of years, and then, you may try to back off and see how someone does. You wait about 6 months to, to see whether or not there's going to be an effect. There are side effects. So, it feels like you're in menopause. There's, hot flashes, fatigue, estrogen decreases. So there's risk for osteoporosis and bone loss. And of note, people used to think or do oophorectomy is when you take out the ovaries, or hysterectomy in acute hepatic porphyria, and there's zero evidence to support that. So contraception, so it means that it's more complicated really than just the ovaries. So contraception and sex hormones. So what do we do? And at the end, we'll talk about a little bit about this project, this survey that we're doing to try to get more information here. But you have a young woman in clinic, and she's sexually active, and she wants to be on birth control. And, so what do you tell her? And that's, again, an area that we really need more data. So this is the data we have. So there was a survey-based study in northern Sweden. So in Sweden, there's, really a big pocket of patients with acute intermittent porphyria. So 166 patients, and oral contraceptives. So COC is combined oral contraceptives, and progesterone only pills were used by 58% of women. 13% of women associated contraception with an attack. And then 6 of 12 women who had attacks on regular contraception actually didn't experience attacks with low-dose estrogen patches given for menopausal symptoms. So, there's definitely a difference. In hormone, what kind of hormones you're using. And then in a separate study of 108 patients in North America, 14 of 33 patients developed worsening symptoms with contraceptive pills, but they didn't really give great data in terms of what pills. And I know we want to get to question and answer, so I'm going to go a little bit quickly through the rest. Progesterone-only contraception. We think that at least the like Depo-Provera, the shot, which is a real big dose of progesterone, and you have a high peak of it and stays in your system for at least 3 months. The implant, the Nexplanon, and probably the progesterone-only pills we tend to avoid. Progesterone IUDs, a lot of people think they're safe. And again, we just need a little bit more data. The progesterone IUDs are really sort of a local effect rather than getting a shot of Depo, where it's, really this systemic effect. So again, we try to avoid progestins, but Mirena IUD, other progesterone IUDs may be appropriate. The morning after pill has progesterone in it, so just be aware of that. Management of heavy menstrual bleeding is very challenging because progesterone is is a cornerstone of sort of treatment. Theoretically, a copper IUD without any hormone should be safe, but we do have a couple of people who, reported worsening of symptoms after the IUD was placed, but also that it's a stressful procedure as well, and it's sort of can be very painful and stuff like that. So it's hard to tease that out. So a couple of slides just on reproductive endocrinology and infertility and assisted reproductive technology, because I know this is an area, again, that we need way more data in, but something that, is very pertinent. So this is a 41-year-old woman with AIP. Her first attack was in 2012 while she was on a diet. She got Heman. Second attack was in 2014 after she had a miscarriage, and she got 2 doses of misoprostol, which is progesterone. Then she had a naturally conceived baby in 2015, did fine during the pregnancy, no porphyria symptoms at baseline. And she wants to do IVF because she's having trouble conceiving a second child. And she comes and she says, Rebecca, what do we do? So there's limited data. There was this study that was published, I think now it was 2021, of 9 women in Sweden, and they got ovarian stimulation. So that's, again, when you're giving typically you're giving hormones, not always, but usually giving hormones to sort of stimulate egg production by the ovary. You retrieve the egg when the follicles are mature, and then you can combine it with sperm and then do a transfer of that embryo on a certain day of the cycle. 6 of these 9 patients had AIP, 4 of 9 had high PBG before the IVF. Only one of the women, though, had ever had a severe attack prior to IVF, and no patients had menstrual cycle related attacks. So this was like a very low risk group to study. This wasn't, you know, somebody having monthly attacks and then you're giving her hormones. These are people who, you know, had, you know, attacks were very few and far between and not related to their cycles. But the point of this that they reported on these 9 patients was that everybody actually did very well. 2 patients were hospitalized for signs or symptoms of an attack, but they recovered very quickly. You know, we generally say, you know, okay to proceed with IVF. I talk very, you know, I have close relationships with the reproductive endocrinologists I work with, and we go over the protocol they're going to use. And I always say, please use the lowest dose of progesterone that you can. And actually, despite, you know, porphyria, the field of IVF has really been gearing toward a more low progesterone approach for a variety of reasons. So definitely possible. So this patient went through IVF. She had 4 embryos with normal chromosomes. 2, so we can test. We do pre-implantation genetic testing, and she wanted to test the embryos for her AIP mutation. 2 had the mutation, 2 did not. She had a transfer of both serially, 1 embryo without, it didn't take, second embryo without the mutation didn't take. And then she said, you know, let's try the ones with the AIP mutation. And she had a transfer of an unaffected male embryo. She got pregnant, did really well during pregnancy, had a C-section just because the baby was breech, and had no complications thereafter. So just as the last data slide. So you know, we talked about contraception, then we talked about IVF, and then pregnancy itself. So a lot of our data in pregnancy and acute hepatic porphyria is very, there's like a reporting bias. So people will report cases that are, you know, really interesting because somebody does very well, but most often they report cases where there's some complication that, you know, needs to be managed, and they, you know, they report the case. So other people can, you know, learn from what happened to the patient. But as a result, there's probably, you know, many women who, you know, have porphyria and do well, but we just don't hear about them because it's an uneventful, you know, thank goodness, pregnancy. So there's this reporting bias a lot in the literature, is maybe when there was some complication that needed to be managed. But so this is sort of the biggest study, 59 patients with acute hepatic porphyria in pregnancy. 70% suffered an attack during pregnancy. Early delivery occurred in 29%. Mean gestational age at delivery was a little early at 35. 45% had a C-section. Human is safe in pregnancy. Again, it's a human-derived blood product, fine to give it. And again, I said this like reporting bias. There's no rigorous data for gavocerin in pregnancy, something that we desperately need. What do we do if somebody is very well controlled on gavocerin and, you know, she wants to get pregnant? So that's a conversation, you know, sort of that we have with our patients. So again, if I didn't tell you this enough, we need more data. What birth control is safest in acute hepatic porphyria? You know, again, probably non-hormonal, like a copper IUD, but we need a bit more information. Some women do just fine on the progesterone IUDs, and some women actually do fine on, you know, combined oral contraceptive pills, like just the regular pill, low dose estrogen and progesterone. How do we treat heavy menstrual bleeding in patients with acute hepatic porphyria? Again, progesterone is a cornerstone of that treatment. How do we best manage pregnant women with AHP? And if a pregnant woman is doing well on gavocerin, do we stop prior to pregnancy? Can we just sort of stop in the first trimester when, you know, you're making all your organs and everything like that, and safely resume thereafter? Ongoing questions. Are there some IVF protocols that are safer than others? we have this women's health survey. And actually, unfortunately, right now it's only open to US participants just because of our institutional review board in our hospital. So if you are a US resident and want to answer some questions about your experiences with contraception and fertility and pregnancy and menopause and everything like that, and porphyria, please email the UPA or me, and we would really love to get your thoughts. And finally, again, I'd like to hear, what you guys have to say, what your experiences have been, how I can help. And, really, we're trying to move this field forward, but we're moving the field forward with with the Porphyria community as input, because that's what we know the questions to ask, because they are your questions. So again, thank you to our patients. Feel free to email me. This is our Porphyria team. Amy Dickey is my co-director at MGH. That is my cat Winston. And I am happy to take any questions. So
Thank you very much, Dr. Karp.
Yeah, sure.
In that study that you're currently doing now, I think it's important for us to also let everyone know that you are specifically looking for those that have been tested, correct, and have confirmed diagnosis through genetic testing.
Yeah, I mean, usually, there's, patients will have genetic testing at some point in their disease journey. Definitely, positive, highly positive biochemical testing. But yes, ideally genetic testing, and, being treated, or having seen a doctor who's, sort of confirmed the diagnosis.
So there you have it, ladies. As you saw, we need all the help that we can get. We will send out a survey, or not survey, but the information that gathers the intake, which then we pass it over to Dr. Rebecca Karp and her team, and then they will just go ahead and send it over. Oh,
I really like talking about periods.
clearly, we don't talk about it enough when it comes to
No.
porphyrias. And
Yeah.
honestly, this is something that you saw the data, ladies. We really need it. We need more information, because without people like you and I being willing to answer these questions and paying it forward for some of, not only for ourselves, but also for our future children, and also just the population in general, it will make a huge difference.
Yeah.
Thank you very much,
I was
Dr.
gonna
Carr.
say thank you, Rebecca. And that's something that I've talked about with my hematologist, was when my family started doing the genetic testing, we were really surprised to see how many people had the gene. And my mom had historically didn't know that she had the disease at the time, but had some pretty rough pregnancies. And, I talked about that with my hematologist, and just as I'm preparing for hopefully having kids in the future, what little bit of fear, and like what my journey was like, is it going to be similar to what my mother's was like? Will I have no symptoms? And I asked him, I was like, do you think that this is just much more widespread than what we know? Because you think of all the women that complain of stomach issues and period issues. And I'm like, I wouldn't be surprised that more women have this gene to some varying degree as they experience, menstruation and pregnancy issues. So
Oh, that's totally true. And people say, oh, you're just a woman, you're having, cramps.
yeah.
Now you have heavy periods, so what, and oh, there's I mean, so much underdiagnosis, for sure. I mean, I think, for you, the knowledge is important. And, luckily we do have, some therapies that work. Again, Heman is very safe in pregnancy. We don't, in somebody who's very well controlled, let's say, she's never had an attack, or she's had, very few, 1 or 2 attacks in her life. If she, during pregnancy, we just sort of check in very frequently, just to get a little bit more information. We'll usually probably check the urine, PBG, every couple of months, just to, gauge. Again, if you're not having symptoms, even if the urine tests are high, we just still say, all right, let's follow you closely, and have a very low threshold to give Heman. So, just having that that knowledge and that relationship with your hematologist, and then you can just, they know you. It's not like you're coming into the ER for the first time. And hopefully, majority of patients we have, not all, majority have done very well in pregnancy. But very low threshold to bring you in for fluids or heman, or if you're just getting, again, like, just first trimester sucks, period. And like, if you're like vomiting all the time, like, that's not good, for porphyria. We want you to have good intake. So bringing you in frequently, giving you glucose, giving you fluids and sort of stuff like that, having that, plan in place is important.
Yeah.
Presentation, Dr. Karp. I do have some questions already from leading up to this conversation. Some people sent in some questions already. So let's jump into those questions, and we will be addressing the ones that you're putting into the chat. So if you have a question, please put it in the chat. You can send it confidentially to United Porphyrias. Anna's managing that, and she will send that over my way so that we can make sure that we go in order. Okay, so here we go. The first question. My daughter was diagnosed last year. She is 16. She is the first adolescent to receive givosiran in the US. She stopped getting her period in September, and I'm wondering if this is because of AIP or a symptom of Givlari. Do you know?
Very, very interesting. So we haven't seen that Givlari, stops periods. Sometimes in women who, and I don't know, how she's feeling, how sick she was, but if your body is just under duress, in general, we see this with athletes, with, change in diet, stress from school, whatever it is, that can, for sure affect your cycles. But shouldn't really be from the Givlari itself. And I think it's, reasonable to for her to not just talk to her hematologist or whoever is treating her, but we have a very low threshold. We have this multidisciplinary group. We'll send patients to endocrinology, measure hormone levels and stuff like that. There's no real medical need to bleed to get the period, but we do worry if the estrogen levels are low for years, it can affect bone health. So, that's just something to look into. But I hope she's doing well on the givosiran. I'm glad she was able to get it, and I really hope that pediatric patients, that we can open the door for more pediatric patients to receive this medication.
Perfect, thank you. In your experience, the hormones used in IVF can trigger a porphyria crisis?
They can, for sure, but I think it really depends on, how symptomatic the person is at baseline. If she is somebody who does get attacks related to her menstrual cycles, and really what sort of protocol is used. So again, IVF has various aspects to it. So the first one really is ovarian stimulation. And that's really when you get, sort of more of the hormones. So basically, what the reproductive endocrinologist does is she gives medications to sort of stop everything. And then you give medication, something called FSH, they're shots to sort of make the ovary produce lots of follicles, lots of eggs. And then you give a trigger shot at a certain point in the cycle where then you ovulate. And then I think it's like 36 hours later, the reproductive endocrinologist goes in and harvests those eggs. So, but in speaking with friends, for multiple reasons, doctors are trying to use less progesterone. So in the study I showed, those 9 women, none of them had, major attacks. My patient did not have any symptoms during her IVF cycle, though again, she had only had 2 lifetime attacks. But our plan was, have a very low threshold to bring her in for heman if she felt like she was, and everyone knows when, usually, when it's coming, low threshold, call me, we bring you in, we give you heman, for 4 days and try to turn things around. So I think that doing IVF is safe. I think it's reasonable. I think you just have a good, you have a thoughtful reproductive endocrinologist who talks to your porphyria doctor about, trying to use less hormones, less progesterone, stuff like that.
Perfect. Thank you. I've been on givosiran for 5 months with really great results. Do we know how long we should be on gavosterin before stopping it in order to get pregnant?
Mm.
And then the second part of that question, do we know how long it stays in the system in order to get through the pregnancy?
An excellent question. The information, the data we have is really scarce, and it's in mice models that the company needed to do before they got FDA approval for the drug. Just sort of anecdotally, if I were to stop somebody's gavosterin today, it would definitely take a few months for their urine porphobilinogen PBG to go up. So probably, if somebody really wanted to stop gavosterin, I would probably say, 3 months, stop it for 3 months before. But, I also think that we don't have any data that it's harmful, in pregnancy yet. And it's this is like such, hand waving means when doctors don't know what they're talking about. It's really hand waving. You have this, you really need to have sort of just an informed decision with the patient and the doctor. And if, the patient says, listen, like gavosterin was life-changing. Like, I can't even imagine not being on this medication anymore. We don't know that it's harmful in pregnancy. I know that if I don't have it in pregnancy, I'm really likely to have an attack, and that's not good for the baby, theoretically either. So, I think that if somebody thinks she can go off of it for a little while, maybe we would try to stop it, ideally 3 months before, maybe even 2 months before. If you can, try to get through the first trimester without it, because again, that's what we think, is sort of the highest risk time. And let's say her symptoms start up again, week 12, and she's really suffering, then maybe, restart it. Because after week 12, really the baby's just sort of cooking in there. It's really all the important stuff is really happening.
Like that.
Or I don't know. I mean, again, I'm definitely not a gynecologist, OBGYN, but so if somebody thinks she can go off of it a few months before first trimester and then start, but if somebody is like, listen, we have no data that it's harmful, I really just don't think I can stop this medication because it has changed my life, and I think I'm going to have an attack off of it. We have an informed decision, and if she says, listen, I know the risks of this, I would say, okay, maybe we keep you on and knowing sort of, the risks, but we definitely need more information. It's not like one of those drugs. There are drugs where we know it's what's called teratogenic, which means that it's harmful to the fetus. It's definitely not a medication like that. And of course, then, there's always Heman in pregnancy. So if somebody goes off the gavosterin, especially, maybe just the first trimester, she needs Heman, weekly or every other week. We always have that backup. It's not as sort of, steady state, but we do have other options. I don't know if that's helpful, but that's why we need.
Very
Yeah.
well.
Yeah.
My daughter was a mosaic gene. I think that means it happened after conception. Her dad, her brother, and myself were tested genetically, and we do not have AIP. Can she still pass it down to her children?
I believe that she can. I'd have to see sort of her. So some rarely, genetic changes can happen not from the egg or the sperm, but sort of at the time of embryo development. So again, I'd have to see her genetics and whether it sounds like it's what's called a germline mutation, which is a mutation that's in her genetic code, rather something that she acquired sort of, later on in life. But, I think so. And again, some women choose, like my patient chose to do IVF with pre-implantation genetic screening. We do that a lot now for various conditions. So, I see patients with hemophilia, which is X-linked. And if a woman has, she has two X's, so she has one normal X and one with the hemophilia gene, and doesn't want to pass it to her kids, she goes to the reproductive endocrinologist, and they can, only implant those embryos without the hemophilia gene. So that's an option if that's, something that sits right, with patients.
I think science is so cool when you talk about the ability to just test the embryo and be able to be so selective. I think that's so cool, by the
I
way.
know. It used to just be like, you would just find the embryos that had normal chromosomes, but now they can do a probe for your, particular mutation. And it's very interesting, very cool.
Yeah, love it.
Yeah.
Thank you for that. I have taken Lupron and I am doing much better as a result. I just want to know, what more can I do to manage my periods and porphyria as I'm only 20 years old?
Okay, so you're on Lupron, it's working, but and I don't know if this is an anonymous question, so I don't want to, but if it's not anonymous, or if you want to email the UPA, I can try to be more helpful. So you're on Lupron, but you're only 20. So again, you know, we do think about bone loss, you know, going forward. It's not a totally free lunch, but for some women, it's incredibly helpful. And what else can you do? So, you know, there is Gavocerin. I don't know if you've tried it. It doesn't work for every single person. Works, you know, I'd say 70% of the time, 70 to 80, but women will still have attacks, will still have, you know, symptoms with Gavocerin, even the phase 3 trial was not, you know, it was not 100% attack free by any means. Always make sure that, you know, there are no other medications that are contributing. I mean, I hate it when people say, don't get stressed out, because like that's like the thing that will make you most stressed out. But you know, if there are certain things in your life that, you know, you feel like you can modify, of course. But Gavocerin is really, you know, sort of the new kid on the block that we use. There's always Heman and fluids. I'll tell you though that so Dr. Carl Anderson, he's at the University of Texas medical branch, and he's like one of the godfathers of porphyria in the United States. He's my mentor. He's like just this awesome person, and he's the one who did the Lupron studies in the 1980s and 1990s. And he said that some of his patients would be on Lupron for like 6 months to 2 years. And then either they would sort of slowly taper it off. So Lupron's either given monthly or every 3 months, or maybe sometimes even every 4 months, you know, and maybe sort of stretch out that interval, give it every 6 months, maybe every 8 months, and then stop it. And in his experience, some women just, you know, spontaneously did fine off of the Lupron. I actually have a patient that used to see him and now follows me. And so we don't know that we need to continue these drugs long term. So, you know, sometimes you cool this down, and then the disease changes, your body changes, something, again, we're not smart enough to know, and you don't need the drug. The same thing for Gavocerin. So at least in the US, we continue Gavocerin, you know, monthly for, you know, as long as somebody is doing well on it. But in Europe, in the UK and in France, there are groups that will say, well, if somebody is doing really well on Gavocerin for a year or two, they'll stop tapering it off every, you know, instead of every month, every 3 months, every 4 months, and then they'll stop it. And their experience, again, it's not a lot of patients, their experience is that patients, you know, do well. So we don't know that we need to continue these drugs long term. On the other hand, if you had such miserable, horrible attacks, you were in the hospital and getting Heman for 10 days, it's very hard to say, oh, you know, let's try to stop your Gavocerin and see what happens. But, you know, that's always an option. I'm sorry, I'm so long-winded. I know there are lots of questions. We'll do another one, Myrna, and sorry, Myra, we'll do another one, and we'll get some reproductive endocrine just here too.
That's a great idea. Okay. The last one then, and then we can answer the remainder afterwards if you want by sending out an email and answering the remainder, because we do have quite a number of questions still left, but I want to be conscientious that we advertise for 1 hour and we want to be respectful of your time as well. We want you to show up to the next event too. We don't want to hug up all your time. So here's the last question.
Iron questions are very, okay. Yeah.
Yeah.
Go.
Here's the iron question. Is an iron transfusion another acute treatment for AIP? I was diagnosed with AIP in 2019, and I've been anemic since I was a child. I had an iron transfusion about 2 years ago, and I've started seeing a hematologist every 6 months since then, and I have not been anemic after the transfusion until recently, and I'm scheduled to get another iron transfusion due to my hemoglobin being dangerously low again.
So, you know, when you think about what heme is, or Heman, when we're giving Heman, so Heman is basically, or heme is, it's something called a protoporphyrin with an iron molecule sort of stuck in the middle. So iron is part of heme, so that, you know, when we're giving sort of heme or Heman, using them interchangeably, you're getting a lot of iron. So I have a colleague who used to say that, if Heman wasn't available now, where we are, we stock Heman because we're seeing a lot of patients, but didn't always used to be available. He said he would try an iron transfusion or iron infusion first while he was waiting for the Heman, because there is iron in heme. So I think that's a really, really interesting observation. I don't know any data that, supports it. It's all anecdotal. But I think that's very interesting that you say it, because heme is important for human. The other thing is just when you're iron deficient, we know this from outside the context of porphyria, iron deficiency is a huge stress on your body. So you're not able to make, as much of the heme. That, sort of process isn't able to go about as it should. People feel crappy when they're iron deficient. They, all kinds of fatigue, brain fog, Charlie horses, changes in temperature. Like, there's just tons of things with iron deficiency. So I imagine also, if you're just feeling better generally, perhaps your symptoms are improved. But these are all things I'm saying sort of just anecdotally. I don't even know if that answers, but yeah.
It does. Thank you very much for answering those questions, and actually all the questions, the presentation, for giving us so much knowledge today, Dr. Karp Leaf. I know that some of these questions were very, very technical, and specifically more towards an endocrinologist or an OBGYN, but you've done a phenomenal job. Thank you for prepping ahead of time
I
to
actually
get here.
studied last night. My IVF friends, I called him. I was like, I'm giving this tomorrow. Let's just go basics. So that's why if I answered them. But anyway, go ahead. Yeah.
Thank you for that. I really appreciate you taking the time. And we promise we will respond to the additional questions. We'll send out an email if you were registered, which obviously you must have in order for you to have received the link. We will be sending out an email with the remaining answers to the questions that we have left. But before we part ways, I want to make sure that you're aware of other resources and events that we have coming up within the Porphyria community. Let me just share these slides for upcoming events that are coming up. Global Porphyria Day is May 18th this year, and we are so looking forward to getting everyone to participate. Additional communication will be coming out soon. Please, please, please make it your mission to be a part of that this year, guys. I know that we can all make a bigger impact if we all decide to put our story out there. If we could just at least once during this time of year for Global Porphyria Day, share our story or something relevant to porphyria. Believe me, not only will it help us within the community, but also doctors or other stakeholders that need to just be aware of what we go through on a daily basis. We're warriors, and we should be proud of getting our story out there. Additionally, we have Patient Day that is going to happen October 12th of this year in Arlington, Virginia. It's actually the International Porphyrias Symposium, and we get the opportunity to get together on the last day and hang out, have fun. A lot of us will be there. If you guys attended Porphyria Palooza, you know that it was just an amazing time to come together and to really feel connected to others. This is what we're going for this particular event as well. So don't miss it. And we also have What's Up Doc coming up. We will be sending out information on when the next one will be, but these are all consistent events that we have at least once a quarter or every 6 months. We like to bring in an expert, such as what we're doing now, to be able to ask any questions and be as get as much knowledge as we possibly can. Aside from that, I urge you to visit our website. Actually, our website has been newly improved. Anna has done a beautiful job with the website, so go on and check it out. And there are multiple ways that you can stay connected year-round. One of them is through Connect Up. These are small groups that meet up, and either it could be by location, it could be by specific subject that you're interested in, or it could just simply be by your type of porphyria. If you go onto the website, it gives you an opportunity to get connected to a Connect Up group, and you'll receive the information from a moderator inviting you to be part of their group. Additionally, we have an ambassador program that was launched last year. It is an amazing program. It allows you to connect one-on-one with a person who can just hear you out and ensure that you don't feel alone. The point is so that you do not feel alone. You shouldn't feel alone because we have an incredible community that's here for you. And we also have a patient navigator. Her name is Erin. She provides one-on-one support for anyone, whether that's, you have a question and you would like to get additional information on your type of porphyria or anything relevant to porphyria. She is amazing. She lives with porphyria herself, so she is able to answer pretty much anything, including if you know a person that is trying to identify if they have porphyria. She helps people get diagnosed, walks them through the diagnosis process as well. And lastly, we have a Porphyria Together group on Facebook. We also have socials in general. TikTok and Instagram is also a huge hangout place for us. So if you're not following us, start following us. I promise you there's great information and connection opportunities as well. And lastly, again, I want to tell you how much we appreciate you being here, how much we appreciate you, Dr. Rebecca, for being here and giving us this incredible information. I want to also encourage you to subscribe to our e-news. If you just go to porphyria.org, it gives you the opportunity to hit join us, and it gives you a chance to get constant updates on a bi-weekly basis on what's happening, what's going on, and also just simply be involved within our community. If you have any stories that you would like to share with us, you can send me an email. My email is Myra, Mayra, at porphyria.org, or you can send it to info@porphyria.org that you are interested in sharing your story, because the more we humanize this awful disease that we fight and live with every single day, the better opportunity to really advocate and create additional resources for us. So would really appreciate you giving us the opportunity to highlight your story and honor you for everything that you've gone through. Again, thank you so much for joining us today, for taking time out of your busy Saturday to join us. And Dr. Rebecca Karp Leaf, you have been amazing. So thank you for taking the time. Thank you for all the knowledge. And I hope that everyone has a wonderful weekend.